Hello, everybody. My name is Baziel Van Engelen. I'm a neurologist in Nijmegen, the Netherlands, and I have the honor to present the overview of scientific advances in myotonic dystrophy type 1 in Europe in the last year. The Scientific Advisory Board of Euro-DyMa consists of 8 people from different countries, as you can see. I will illustrate them a little bit later. Euro-DyMa has a firm connection to Optimistic, which was an EU-funded collaboration between several centers in Europe, between France, the UK, Germany, and the Netherlands. And based on the data of Optimistic, Recognition, another EU project, is now actual and is trying to find druggable targets of patients that improved during the Optimistic trial. And Optimistic, as you can see, is populated by patient representatives, doctors and researchers, as you can see here, from different countries, from Paris, Glasgow, Nijmegen, Dundee, München, Newcastle, and Aberdeen. As you know, myotonic dystrophy type 1 is probably the most variable, the most heterogeneous disease around. And we are going to make use of this heterogeneity, of this variability, and trying to find differences between people that have DM1 and have an excellent life compared to people that have more symptoms in DM1. And we try to understand on a molecular level what the difference is, and if we can support the patients with drugs that imitate the improvement. And Alain, and also Peter Bramatoon and I give a short introduction on a European broadcast. So the basic idea is that a patient with DM1, we give them CPT, cognitive behavioral therapy, without or with exercise. And we see responders and non-responders. And responders are patients that improve. And then we are going to look at the biomarkers in blood that are associated with improvement. Can we understand the improvement when we look at the blood? And then we're going to look for drugs that can imitate this improvement. So to summarize, when we give patients with CPT, half of them, we give them cognitive behavioral therapy with or without exercise. We look at the overall benefit. Some patients benefit, others not. And we are looking at the underlying mechanisms in the patients that improve in search for novel drug targets. So that is the basic idea between Optimistic, and we are now testing it in Optimistic 2.0. I will come to that a little bit later. Together with Alain, we also wrote for the patients, and that's what we investigated in Recognition. In Recognition, we make use of the material that we collected in Optimistic, and we are looking for these druggable targets. So there's a close connection between Euro-DyMa on the one side, the European collaboration on myotonic dystrophies, with Optimistic, Recognition, and as you know, we are now able to start Optimistic 2.0, and we will continue, and I will speak on that a little bit later, I think next year, about how we are going to start Optimistic 2.0. But for now, I would like to summarize the different, let's say, clinical advances and scientific advances in Europe in the last year. And this is the Scientific Advisory Board. There is Dennis Furlong from France, Darren Monkton from Glasgow, the UK, Guillaume Basset from Paris, Benedict Schoser from München, Anne-Berit Ekström from Sweden, Giovanna Miola, a neurologist from Milano, and a new member is George Papadimas from Greece. So several of the participants of this Scientific Advisory Board were already a part of Optimistic and Recognition, 2 EU projects on novel treatments in patients with DM1. So we had our first scientific meeting with patients and patient representatives in Euro-DyMa, And we choose to review the contribution from last years of the various scientific Euro-DyMa members themselves. This turned out to be a fruitful approach. I myself reported Dutch studies on mechanical ventilation and brain characteristics in DM1. In addition to some new results of optimistic, for example, the increase in muscle mass after increasing physical activity in DM1 patients. So we found that patients with DM1 that were more active had not a decrease in their fatty infiltration in muscle, but has an increase in muscle mass. So the already healthy muscle can improve in patients with DM1. Dennis Furlan from Paris spoke about more basic studies, more fundamental studies on novel treatment approaches. For example, as you have heard, probably CRISPR-Cas-based methods, trying to repress what is called autophagy, which is the garbage function of the muscle. And in DM1, this garbage function is a little bit exaggerated, and they are trying to suppress this exaggerated garbage function. Darren Monkton reported several basic studies also on and highlighted the molecular commonalities between various diseases that are a little bit similar as DM1, like Huntington's disease. So Darren tries to understand DM1 by looking also at other diseases that are similar, like Huntington's disease. And he cross-compares different scientific fields in treatment development so that the DM1 patient can also gain from the insights that are made by Huntington's research. Guillaume Baziel from France commented on a multi-center study of pediatric DM1 and participated in a study showing the relationship between the milder clinical phenotype and variant repeats. So when the repeat has variants, then the patient have less symptoms compared to the repeat without variants. And with a variant means that it is not a regular CTG repeat, but that there are also repeats in between. And when that is the case, then the patients have less severe clinical phenotype. Benedict Schoser from München stressed the importance of also including DM2. So we are not only investigating DM1, but also DM2. And he published overview papers on outcome measures, daily activity in DM1. And in addition, he published an important paper about dyslexia, not able to read, not being able to understand what you read, which is highly relevant for assessing patient-reported outcome measures. When we ask patients to fill out questionnaires and they have difficulty reading it, then we are not testing the DM1, but we are testing if patients are able to read. Anne-Berit Ekström published on dental changes and daily activity in children with DM1. And the dental changes are a little bit understudied in DM1 and are important for patients with DM1. Then, nearly finally, Giovanni Meola mainly discussed his papers on brain aspect in DM1. He is really the one that studied the brain probably the most worldwide. And he found white matter changes in the brain alterations affecting decision-making and abnormal cortical thickness in relation to social cognition. That means the cognition to know how you have to behave to other people. And he showed also that the abnormalities on the MR imaging were connected to decision-making problems. Our new member, George Papadima from Greece, reported on neuropsychological assessment in DM1 and the effect of exercise training on functional capacity in DM2 patients. So he did a big trial in patients with DM2, just as we did in Optimistic. We tested patients with DM1, George Papadimas did it in DM2, and showed the beneficial effect of exercise training. So this was like a bit of a summary of the clinical advances, at least in Europe. And as you can see, there is a broad range of clinical as well as basic science improvement in the DM1 as well as the DM2 field. I thank you for your attention.